Good morning. My name is Joshua Swan. I'm a pharmacist from Houston Methodist Hospital, and I'll be one of your moderators this morning. We actually have 6 speakers and 2 moderators, so there'll be an exercise and people coming on and off the stage throughout the course of the session. Today our session is titled 50 Shades of Delirium. I did not pick the title. But I think we're going to have a nice talk. I think our faculty are excellent, and they've really been advancing the field and involved in the last set of guidelines, and a lot of these faculty are involved in the next set of guidelines. And I think they'll talk about sort of what we know about the phenotypes of delirium and how to approach it. And I think equally importantly, they'll be talking about the things we don't really know yet. And I think delirium is a field where we still don't know a lot about the disease. Our first speaker this morning is Yoanna Skrobik. And she's at the McGill University and McGill University Health Center, and she'll be talking to us about improving delirium phenotypes. So if y'all could help me welcome Dr. Skrobik to the stage.
Thank you. I'm delighted to be here. I am a member of the guideline committee for the current sleep and early mobility, pain, agitation, delirium guidelines. And I say that's a conflict of interest because I think that opinions are strong and there are many Hawthorne effect attempts. I'm also the holder of an academic chair, and these companies contribute to the academic chair. I assure you I have not benefited from their generosity. And this morning I was asked to talk about the improvement of delirium phenotypes in the context of a session that we didn't choose the title of and felt our hands were a little tied. But when you look at the phenotype definition, what phenotype means is a set of characteristics that are an interaction between genotype and its environment. And I am not sure that I can live up to the expectations of this session, which is how to improve the phenotype and fulfill all of these other goals because they're quite lofty. So what I would like to do is to change the question a little bit and wake you up with a bit of an iconoclastic morning and ask the question whether delirium does in fact have phenotypes or not, and talk a little bit about the diagnosis of delirium without doing it in as structured a way as the subsequent speakers will, talk about the trouble with detection rules, and talk about the genetic association in one slide only, and then move on to trying to talk about how delirium detection and quantification can be made better, because that's really what we want. I want you to think back about the notion of diagnostic rules in psychiatry. In the U.S., the original census of psychiatric diseases was to tally the frequency of idiocy and insanity in the 1840 census. I will completely step aside from the temptation of any political humor at this point and tell you that by 1880, categories of mental health were created: mania, melancholia, monomania, paresis, dementia, dipsomania, and epilepsy. And those were considered the main categories of diseases that made people neurologically or mentally fragile. A few historical elements played into the creation of the rules as we know them today. This is a picture of Dr. Cameron, who was at the Allen Institute in Montreal at McGill University, where I work, whose conviction that electroconvulsive therapy could rewire your brain and cure any ill led to to the CIA being very interested in his work and paying him for it, in the thought that maybe they could also erase memory while they were at it. And the class action suit that followed depicted the horrors of patients who were hospitalized in a psychiatric institution and subjected to experimental interventions without any form of consent. And this is a picture of Joe Kennedy's daughter, who also was seen by a psychiatrist. Her behavior was deemed to be inappropriate, and she underwent a lobotomy. So these sort of historical and later publicized elements led to the need to create criteria that were really rigorous and particularly attentive in terms of psychiatric patients who were considered vulnerable. And these are the DSM IV criteria that underpin most of the diagnostic approaches to patients in the ICU. And I'm putting them out for you because they are actually the only DSM criteria that are based on phenomenological observation. all delirious patients had all of their symptoms tallied in 2 large studies, and people compiled these symptoms and created what is probably one of the most rigorous psychiatric diagnostic definitions. But the problem with any of those boxes and the problem with any of the frameworks is that if you use the ICD-10, which is the list of diagnostic criteria used in Europe more than it is in North America, or the DSM III criteria, or the DSM IV criteria, and apply them to a similar population by experienced psychiatrists, you end up with different numbers in terms of who actually has that disease. And I think this is nothing new to any of you, but when we are talking about delirium phenotypes, we're not talking about a troponin detectable disease where there's an EKG abnormality and a biochemical signal that comes along with it. And in fact, when you look at how consultations, liaison psychiatrists approach the diagnosis of delirium, they use these DSM criteria as boundaries, but they also explore the patient's lived experience and ask them what their imagery is like, what their anxiety is about, what the mental representation of their disease is, and go on to consider ideas and delusions as facts and paint an anthropological landscape, and then look at the patient's affect and decide whether this affect, the context of the medical experience, where you're between life and death, right? You could argue that it would be curious to not get PTSD when you're an ICU patient because of all of the factors that are surrounding it. So some abnormality is expected, and where does that abnormality cross the line into pathology? And it's a little bit, and I'm not trying to refer to the 50 Shades of anything, it's a little like pornography, right? You know it when you see it. And there are some cases where you absolutely know this patient is delirious. They were fine in bed the day before, and they have psychomotor agitation. They're grasping at insects that aren't there. They're picking at their sheets, which are, symptoms that were diagnosed, but that were described by Hippocratic students in ancient times. But it's the ones that are not quite that classical that I'm going to address labeling, because it's important to get the label right. Delirium, when it occurs, is extremely distressful. It's distressful to the patients who are aware of the fact that they have it. 4 is the maxed out stress level that you could possibly achieve in any of your moments of distress. But their loved ones and the nurses who look after them also find the experience very distressful. So we use standardized ICU delirium screening, and I have to say I was one of the instigators of this initiative, because I really thought that we should be able to say who had these delusions and who didn't, because I thought it was really important to reassure them if they were scared and tell the families this is what's going on as part of ICU care. I thought it was important to identify it. But one of the biggest challenges that we have is that disturbance of consciousness, which is sometimes part of our practice, is also part of the diagnostic definition. And I'm going to focus only on this aspect of potential confounders and not dwell on the other psychiatric diagnoses that people have been attributed in the context of critical illness. So when you look at DSM IV criteria and you look at the disturbance of consciousness, whether the level of sedation that's been given to a patient actually confounds whether you can tell that somebody has a CAM-ICU positive score and is or isn't delirious, or an ICD-SE score, was brought up by Matthias Henge's group and published in Intensive Care Medicine a few years ago. And in that, in the follow-up to that article and a thorough review of the literature for the purposes of the current guidelines, Gil Fraser was thorough enough to go through a number of papers that I'll refer to in the next slide and look at how much RAS levels and CAM-ICU assessments correlate. And on first pass, what he described is that in RAS levels of -2 to -3, 76% of patients are described as being CAM-ICU positive, and whereas only 22% are with RAS levels that are lighter. And what he looked at were 4 observational trials tallying over 12,000 CAM-ICU assessments where various RASS levels were also described simultaneously. And this is where the challenge is, because a lot of publications don't actually show the two at the same time. And he looked at and added up what happened when the RASS was -2 to -3 and found that the incidence of delirium overall was 75%, 0 to -1, it was 22%. So John Devlin and Gil and Aaron Jaffe and Rich Reicher and I published this paper to comment on the very high variability of positive CAM-ICU assessments across different papers in rather similar populations, with 1 or 2 exceptions, and it commented also on the high variability in the ICD-SC and said there's a problem with the signal that's this variable, and we wondered whether the sedation confounder wasn't part of the reason why the delirium assessments were so different. Why does it matter whether it's sedation assessment positivity, sedation-related positivity or not? Well, in this paper from the Chicago group headed up by J.P. Kress, Dr. Patel showed quite elegantly that if you have delirium that is associated with sedation, which means that when you lighten the sedation, the patient wakes up. They deemed this term sedation-related delirium. Your prognosis in terms of ICU length of stay or mechanical ventilation or hospital length of stay is in fact identical to that of people who don't have delirium on any screening. But if you if your delirium assessment is positive when you're awake, that confers a very different prognosis. And so that's the importance of the sedation association. This association of risk is also translates into something that the patients really care about, which is where they go. So if you go home, you are happiest, and that is most likely if you have no delirium, but it's as likely if you have that rapidly reversible sedation-associated delirium, but it's not true if you have a delirium that is detected when you're awake and able to fulfill the assessment. And this is a slide showing how difficult it is to actually do the assessments when you're at RASs of 0, -1, and -2, but also how likely you are to be scored as delirious. And you can see that there's a relationship between the depth of sedation. And when I look at papers like Pratik Pandey's elegant work from several years ago associating delirium with doses of Lorazepam, I always wonder whether we're not just looking at the dose of Lorazepam because of the sedation confounder. And so the diagnostic difficulties of true incidence with delirium are actually important, because we don't want to be giving antipsychotics to people who are not delirious, nor do we want to miss people who need to be reassured or who need to be intervened with if we can come up with any intervention that actually works and is really efficient. And I think that the issue of which delirium symptoms are present and which ones confer risk is actually still unanswered. In the paper that we published in 2007 or 10, I can't remember now, I'm sorry, we looked at psychomotor agitation and other symptoms of delirium like hallucinations and delusions and found that they individually prognosticated in people who were not delirious. So if you were agitated, that was bad if you weren't delirious, and if you hallucinated, that actually appeared to be protective in terms of prognosis. But when we looked at who was agitated and who was not, of all of our patients who were delirious, all had either psychomotor agitation and psychomotor slowing at least once. And to my knowledge, this is the only paper that actually looked at and counted all of the symptoms in all of the patients who had both delirium and didn't have delirium. And so the prototype is not very clear to me. The sedation is clearly a confounder. And the genetics question was very recently reviewed in a nice systematic review by David Marr and the European Delirium Association group, suggesting that there's absolutely no association between the APOE gene, which is the only one that has been suggested as potentially being related to delirium. So I'm not sure a plausible argument for a phenotype can be made, and there is a high variability in recognition with the tools that we do have, and that in and of itself is problematic. We use them because we want to make sure that between ourselves we're all speaking the same language, but I think that you can understand that I'm actually skeptical about whether they're true. Should they be done? Absolutely they should be done, because you need to be asking those questions. Are they perfect circuits? Certainly not. And if I can make a few suggestions about how we can maybe make the experience better, in addition to talking to our patients, because if your patient's not agitated and he or she is not afraid, then whether they're delirious or not may or may not warrant intervention or anything other than non-pharmacological interventions like reassurance. But if you're not asking the person if they're frightened and not reassuring them for that, we don't have any studies that measure reassurance for fear by nurses or by physicians, reassuring patients that they are not going to stay nuts, that they are going to get better, that they are going to make it out of the ICU. We do not have randomized controlled trials looking at those kinds of interventions, whereas the patients that I've looked after for the last 20 years tell me that that really matters a whole lot. I also think that when we look at data to make recommendations, we don't look at qualitative data. We don't ask patients what it was that made them feel better to then drive interventional studies. And I think that that's a bit of, I'm hoping that that pendulum will swing, because I think rigor and methodology are extremely important, but I think that we don't necessarily have enough answers to drive the studies that we're doing right now. So I hope I've gone over these 4 points that I presented to you early. And to the question how we can make it better, one of the other suggestions that I would have, this is my MOC pre-test for the SCCM Congress, and you can see that I answered the wrong question, which was mixed alternating between hyperactive and hypoactive based on my own work, and the right answer, I don't think, is the right one myself, personally. Thank you very much.
So big thanks to Dr. Skrobik. One thing I forgot to mention is because we have 6 speakers, we're going to withhold all questions to the very end of the session. We'll hold a question and answer panel with our faculty at the very end of the session. Our next speaker, if we can go ahead and bring the slides up, is going to be Dr. Michele Balas. She's an associate professor at The Ohio State University, and she's going to speak to us about improving delirium care, modifying risk factors. If you could all welcome Dr. Balas.
Good morning, everyone. Greetings from the great state of Ohio. OH? Yay! Here we go. I have the wonderful pleasure of sharing with you today probably a bunch of information that you already know if you're in this room and have some interest in delirium. Here's my disclosures. What I'd like to do in this brief period of time is to really share with you some of what we know so far about the etiologic causes of delirium in the ICU and some potential therapeutic targets. Yoanna obviously does such a great job with her presentations, and hopefully we'll have a really vibrant discussion at the end, particularly about the need for more qualitative research. So she touched on the point about the current challenges that we have with the accurate assessment of delirium. And she challenged me not to put the DSM criteria up on the slides because of the controversy that exists, particularly around the points surrounding level of consciousness. I didn't listen. Consistent with the theme of this 50 Shades, I thought some controversy might be good. But just to review again briefly, when we're talking about delirium, people, I think, are pretty much aware of that change in attention and awarenessness, the change in cognition. I bring up the criteria to really focus on this last point. So in the DSM, they clearly outlined that there's evidence from the history, physical exam, or laboratory findings that the disturbance is a direct physiologic consequence of something, right? So it's either occurring because of another medical condition that may or may not be diagnosed yet, substance intoxication or withdrawal. Anybody here have any problems with substance abuse in their intensive care units? I know it's a rare phenomenon, but just keep it on your radar. We might be getting some attention lately. But clearly, we have an epidemic in terms of alcohol and opioid addiction in our country. So we are admitting a lot of patients with those unfortunate disorders. Exposure to a toxin or due to multiple causes. So in general, delirium is caused by something. We're still at the edge of trying to understand what the exact causes are. I love this quote. I did. I told you I had Albert Einstein in here somewhere. I always try to get him in. If you can't explain it simply enough, you don't understand it well enough. And that's something that we've been trying to do in delirium research over the course of last year, is make this as easily understandable as possible. So we have some consistency in how we're speaking to each other, different colleagues, different professions. So we have the same language and know that we're talking about. And I'm happy to say Dr. Sharon Inouye's work, and I look back, it's 1996. She really shared with us this great way of envisioning delirium and risk factors. And I don't know if you're familiar with this, but she explains, and I think pretty simply and eloquently, that really your predisposition to developing this disorder does come about from a mixture of patient factors and precipitating factors. We also know that some patients will be a much higher risk of developing delirium during their ICU stay, and some are at lower risks. So this mix of predisposing and precipitating risk factors has really been almost like a conceptual model that's been guiding the research in this area. So why do I have a picture of a guy with a pig? That was another question that was brought up in this one. I personally just really like this picture. But it's used to visually illustrate some of the risk factors that we know. So again, when we talk about those predisposing risk factors, what does the literature tell us about it? And when I prepared this presentation, I went through probably about 75 different studies that have looked at what are the risk factors for delirium. And there's some great systematic reviews, and I have it on my last slide if anybody's interested in getting some of the primary work that's been done in this area. But we know there are some things that put people at higher risk for delirium: age, sex, substance abuse, hence the picture with the pig. I don't know if a pig will cause you to be delirious, but that alcohol, cigarettes, and male gender do seem to be associated with a higher risk of delirium in the ICU. We also know patients with very specific comorbidities, cardiac, respiratory, neurologic injury, very controversial area. Also get tons of questions about whether or not the neurologically injured could develop delirium. We kind of try to teach people that it's obviously you can get a secondary form of brain injury when you have neurologic injury, so supposedly, yes, it's possible. Non-English speaking language and severity of illness will put you at greater risk. There's also some that are really not modifiable, and they're really associated with the different kinds, the different diagnoses that we see. So people with sepsis, ARDS, again, probably related to that severity of illness, higher risk for developing delirium, emergency surgery. There are trauma folks, and unfortunately struggle with this disorder quite a bit in their population. And some of the risk factors are a little bit more modifiable, right? So whether or not our patients remain hypotensive for prolonged periods of time, some evidence in the literature that transfusions might be associated with delirium, and of course, a number of different lab abnormalities. I like to focus on those risk factors that are potentially modifiable. So what we know in the literature is that there are a number of things that put people at higher risk for developing delirium during their ICU stay, and some of them involve symptoms. Symptoms such as pain, anxiety, and the way that we treat them. Patients on mechanical ventilation, much higher rate of becoming delirious during their ICU stay. Physical restraints. Outside the ICU study, outside the ICU setting, there's much more information on the effects of physical restraint use. And interestingly, when you look at that data, many people give the reason or the indication for physically restraining patients is that they're confused. So the patient's confused, so we put physical restraints on them in an attempt to treat the confusion. Now, if we can just sometimes sit back and reflect on some of the things that we do in practice, I'm not really quite sure how restraining a patient will actually help resolve that confusion. Another indication is, obviously we don't want patients to pull out those important lines and tubes, so physical restraints are applied in that setting as well. Unfortunately, even though there's not a lot of great randomized controlled trials, the gold standard, we know that actually the application of physical restraint use does the exact opposite in many cases and actually elevates a patient's risk of pulling out mechanical their ET tube or other lines and tubes that we need in critical care. Keeping patients in bed rest, immobility, seems to put you at greater risk for ICU delirium, and actually the research in that area shows that actually one potential non-pharmacologic strategy is to get our patients up and moving. Now, there's as always, there's usually two sides to that equation. There's some people that advocate that the effect of physical exercise actually reduces the risk of delirium. And then there's also the other camp that thinks, well, of course they're going to be less delirious, because to get patients up out of bed and walking when they're on the ventilator, they're not going to be able to be sedated. So again, we get back to that question, is what we're seeing really the side effects of the sedation that we're using in the intensive care unit? There's some things that seem to reduce the risk of delirium. Pre-admission statin use, these are all very preliminary. Melatonin, I think that this is actually probably one of the neatest areas that we'll be seeing in the next couple of years develop. What is the role of melatonin in terms of sleep in the intensive care unit, and is there a potential role for melatonin in the treatment of delirium? And I don't know if any of our other speakers will be touching upon that. Use of earplugs has been shown in some quality improvement work in particular to reduce the risk of delirium. I kind of worry about that a little bit, because particularly with our older adults that are admitted to the intensive care unit, I think if we take away any of their sensory senses any more than they already are reduced, it might be a little problem, but has some evidence behind it, and also keeping the vital signs. I should have looked up, I admit, standing in front of all of you, I don't really know much about Voltaire, but I love this quote. In terms of really, we know very little about the specific causes of delirium. And unfortunately, we know sometimes even less about the medications that we're using to treat this syndrome. We do know that there's been a number of studies, like Yoanna explained, that have been shown that these medications in particular are associated with delirium. Now, is it a chicken or the egg thing? Again, we're not clear, but there does seem to be an increased risk of delirium, particularly in the older adult population, and studies consistently outside the ICU still show this, with particular classes of medications like benzodiazepines, opioids, even our antipsychotics, steroids, and other medications. So, what can we do potentially based knowing on these risk factors? Now, Dr. Julie Barr is going to give a great explanation of how we could really impact clinical practice and change how we're caring for our patients in their ICU to reduce this disorder. But I think with those risk factors that are not modifiable, so the guideline with the pig, with the cigarette, and the alcohol, there are things that we can't do. But if we know our patient's going to be at higher risk, we can use that information to put into place some prevention protocols if necessary, stratifying their risk based on those predisposing risk factors. I think we have a great opportunity to improve symptom management in the intensive care unit, knowing that the development of symptoms does increase your risk of delirium. What a great opportunity to look and prevent some of the symptoms. Adequately treating pain, using non-pharmacologic interventions like Dr. Klein's work with music interventions in the intensive care unit, patient-selected music. That was very important to know, because we don't want to be playing rap for our 85-year-olds that are in the intensive care unit. I don't even know if rap's cool these days. But really using non-pharmacological interventions like music or what the patients find calming and relaxing. We don't really, how many of you, this is just a quick poll, how many of you even assess for anxiety? Oh, well, that's great. And hopefully that we'll more and more intensive care units, because that symptom in particular hasn't gotten the attention that others like pain have over the years. But assessing, I mean, we treat anxiety all the time, but how, at least we say we're treating anxiety all the time, but if we're not measuring it, is that really truly what the patient's experiencing, or is it other symptomologies, shortness of breath, pain? So really the importance of assessment there. Improving communication ability. Numerous clinical experience on my part, and the work that's been done by so many great researchers in this area, in particular Mary Beth Happ, really given our patients the ability to communicate and to let them, as Yoanna said again, tell us what they need, what they're experiencing. I'm sure all of you, if you've been a clinician for longer than a day, have had the opportunity of caring for patients with hyperactive delirium or patients who are hallucinating, and just giving them the ability to tell us what they're experiencing could lead to very effective interventions. I had one patient that I'll never forget who insisted that there was an Indian in his closet, and he was scared to death. Indian in the closet. He's going to kill me. He's going to kill me. And I had a great physical therapist that worked with it at the time. And, after doing my real hardest to be patient and try to reassure him, there's no Indian in here, you're safe, and the intensive care, everything that we teach our nurses to do. I was getting frustrated. And the physical therapist looked at me and he's like, "Did you check the closet?" No, I didn't check the closet, but I'm pretty sure that there's no Indian in the room. Well, sure enough, great teacher, he went over and opened the closet. There was a hat in there. There was the chains that we used to use for mobility, and there was a coat underneath the hat. So when you're clearly sitting at the other end of the room without your glasses, interpreting that cue would be very important. And there was our Indian. The Indian went away. I took out the chains. There we go again, another reference to the 50 Shades. Took away the chains, took away the hat, and the Indian went away. How simple is that? Just having time to have that ability to communicate with our patients. Going backwards again. I'm going to wrap it up here with obviously the area that I'm most passionate about, and this is the ABCDEF bundle. Dr. Barr will tell you more about it. But really, this has been, over the last few years, where I've been putting a lot of my emphasis. The ABCDEF bundle is a set of evidence-based interventions that have been associated with reduced delirium. So when I had the pleasure of doing the Robert Wood Johnson study when I was at the University of Nebraska, go Red, Cornhuskers, our study, before-after study, actually showed a halving of the odds of delirium when we put this bundle into place. Really simple bundle, a lot of parts, hard to implement. But really, the A stands for assess, prevent, and manage pain. If we take away, or at least alleviate to the best of our ability, patients' pain, and really focus on that accurate assessment and the humanity that's involved in that, really having some opportunity to make some delirium reduction improvements there. B, both spontaneous awakening and breathing trials, letting the patients breathe on their own once a day, shutting off their sedation once a day to let their head clear and for them to come above water. Choice of analgesia and sedation. We have great presenters that are going to tell us all the lovely work that they're doing with the medications that we currently have available. But right now I'm of the camp, we have none. And I am not of the antipsychotic camp, so that's my disclaimer. Show me it works, and then we'll do it. I'm not saying that you can never do it. Obviously, there'll be patients that need it. Delirium assessment prevention, early mobility and exercise, getting those patients up. And finally, F, engaging our families and patients to be more active and participatory in their plan of care. Having our families engaged while they're at the bedside and doing those things that the patient tells us is most helpful for them. So I look forward to our discussion. I hope you guys are having some great questions as you sit there and hear these great speakers, and look forward to talk to you in a bit.
Well, good morning. That was great. I have the pleasure of introducing our next three speakers, who are all pharmacists, and they're going to be talking about some drug therapy for the treatment and prevention of delirium. So our first speaker today is Dr. Erin Roach. So Erin is a critical care pharmacy specialist at Carolinas Medical Center in Charlotte, North Carolina, and she's going to be talking about alpha-2 agonists as a potential solution for treatment and or prevention of delirium. So please join me in welcoming Dr. Erin Roach.
Good morning, everyone. So I have no disclosures to report. And today we're really going to kind of analyze the primary literature available on dexmedetomidine's impact on both the incidence and treatment of delirium in critically ill patients. We'll review a little bit of a niche area with clonidine as far as what role can that help us with in nowadays healthcare with examining cost. And then finally wrap it all up with discussing the place in therapy of alpha-2 agonists. So briefly, dexmedetomidine, as we know, is our selective alpha-2 adrenergic agonist. Its selectivity for the alpha-2 receptor is about 1,600 to 1, compared to clonidine at around 200 to 1. So through its actions on the presynaptic cell bodies in the locus coeruleus, there's an inhibition in the release of norepinephrine, which then prevents the excitation of the postsynaptic alpha-1 receptor. Classic pharmacy information, it's hepatically metabolized via glucuronidation, as well as CYP-mediated metabolism on 2A6. Adverse reactions include bradycardia, hypotension, and then with rapid IV administration or very high dose administration, patients can experience hypertension. So there's many potential mechanisms in how dexmedetomidine may benefit patients with delirium or act in delirium. As I've already said, it decreases norepinephrine release. There's decreased glutamate in the brain with dexmedetomidine. There are no anticholinergic properties of dexmedetomidine, which we know anticholinergics can, in fact, induce delirium. Does not induce REM state sleep. However, there is potential benefit with slow-wave deep sleep in patients, with that being an area of examining how much our ICU patients are actually sleeping every night. Potential anti-inflammatory effects as well as positive immune effects with actions on macrophages and anti-apoptosis. It does not, in its mechanism of action, contain GABA properties, or simply using dexmedetomidine allows us to spare opiates as well as GABA agents in patients, and this could be the area of why there is potentially benefit. So our map for today will look at studies that evaluated dexmedetomidine on the incidence of delirium, focusing on those that used it as a primary outcome. And the first study we'll look at is the MENDS trial published in 2007, and this was an examination of dexmedetomidine versus Lorazepam on acute brain dysfunction. So not just a delirium primary outcome, but it was a composite of delirium-free and coma-free days. So you're getting patients all along the spectrum of the RAS. So CAM ICU positive, as well as those patients that fall into the RAS of -4 and a -5. This was a med-surg patient population that was mechanically ventilated. And you can see here the randomization to dexmedetomidine or Lorazepam for up to 120 hours or until the patient was extubated. As far as outcomes, there was a statistically significant increase in delirium-free and coma-free days in these patients. However, when we break it down, we break down the composite to look at exactly which endpoint contributed most to the statistical significance. It unfortunately was not delirium-free. So as well as the duration and prevalence of delirium was not reduced specifically in this particular endpoint. There was, however, an increase in the rate of patients that were within 1 point of their physician-directed RAS goal. Beyond the MENDS study was a pre-designed a priori analysis that was comparing septic patients to patients without sepsis in the comparison of dexmedetomidine versus Lorazepam as their primary sedative. And what we see here is the same outcome carried forward, that there is a statistically significant benefit in the composite of delirium-free as well as coma-free days. However, there is no specific benefit with delirium-free days. Also, something that is intriguing yet should be interpreted with caution, as this was a subgroup analysis, was the mortality benefit in patients with sepsis that received dexmedetomidine versus Lorazepam, which further brings in the potential for the anti-inflammatory immune-mediated reactions. Is that something that is coming into play here? Sue and colleagues of this past year published a study looking at dexmedetomidine to prevent delirium in elderly patients that were post-op from non-cardiac surgery. They examined the incidence of delirium within the first 7 days after surgery, and this was a very large study at 700 patients. Patients were randomized to receive very low-dose dexmedetomidine that was not titrated at 0.1 mics per kilo per minute. Those that were not intubated received dexmedetomidine or placebo until 8 a.m. the following morning, so they received at least 12 hours of therapy. And then those that were intubated received dexmedetomidine or placebo once they kind of emerged from their anesthesia and were back in the ICU, so RAS of -2 or higher. And what we can see is that postoperative delirium was greatly reduced at 23% versus 9.1%. In their examination, they did find that the incidence of delirium was not statistically significant until patients had received at least 12.25 hours of dexmedetomidine. So that's briefly how we kind of know the literature for prevention of delirium as a primary outcome. The next step would be looking at specifically dexmedetomidine to treat delirium. Reed and colleagues published a pilot study in 2009 that to me, had a very intriguing methodology. So they looked at 20 patients who were mechanically ventilated and could not be extubated purely because of agitated delirium. So for all other reasons, these patients were ready for extubation. However, their current mental state was the precluding factor. They were randomized to dexmedetomidine or haloperidol continuous infusion, and they were able to find that dexmedetomidine had a significantly shorter time to extubation compared to patients with their agitated delirium being treated with haloperidol. They followed this up this past year with the Dahlia study. However, we lost the haloperidol comparator arm, so this was dexmedetomidine compared to placebo. So this is in addition to standard care. So patients were being treated according to the standard up until the point where their agitated delirium was precluding extubation. Other key, there were many secondary endpoints, but key for us here is time to CAM ICU, first negative CAM ICU, as well as concurrent use of other antipsychotics. And what they showed us was that there was around almost 20 additional ventilator-free hours in patients that received dexmedetomidine versus placebo, as well as a shorter time to CAM ICU negative, which was their endpoint to say resolution of delirium. So 23 versus 40 hours of a duration of delirium, as well as patients receiving dexmedetomidine did receive less open-label antipsychotics. And you can see in the graph their time to extubation, or proportion of patients remaining intubated. Also, this past year, so 2016 was a big year for dexmedetomidine and delirium, but there was a study published in just this past year looking at hyperactive delirium refractory to haloperidol in non-intubated patients. So Dahlia gives us an answer or insight into intubated patients, but what about your non-intubated patient that is maybe having delirium as a barrier to transfer out of the ICU? So they had co-primary endpoints for effectiveness as well as safety, percentage of time within the goal RASS, as well as rate of excessive sedation. Somewhat of an interesting methodology to kind of grasp as far as the time points in the study, but patients were all initially receiving haloperidol, followed by a continuous infusion haloperidol. And at that point, they were assessed as either responders or non-responders. And the non-responders then went on to receiving dexmedetomidine. Only once patients had the delirium controlled in each arm were they then analyzed for the primary outcomes. So for the percentage of time within goal RASS, significantly higher percentage of time with dexmedetomidine, as well as minimal to none, essentially, rate of excessive sedation, which, knowing the characteristics of dexmedetomidine and using dexmedetomidine in practice, I'm not entirely surprised that there was no excessive sedation, getting into those deeper RASS goals. So you've started your patient on dexmedetomidine. Maybe they were an extubated patient. And now you've got them on a continuous infusion, which is just as much of a barrier to transfer out of the ICU. So where do you go from here? Briefly, Clonidine, as I said, has a selectivity for the alpha-2 receptor at around 200 to 1. Major routes of administration are going to, for the most part, be oral, so it can be swallowed or crushed, which is very important in our critically ill patients. It is okay to give via the tube. Can be given sublingual, as well as we think, oh, this patient just pulled out their oral access, let's put a Clonidine patch on them. However, you have to know your limitations on your routes of delivery of drug. The Clonidine patch does not achieve steady state until 72 hours. So, in 4 days, when you're ready to control their agitation with the Clonidine patch, you could have transferred them to the floor a lot sooner with an alternate route of administration. Once again, similar adverse reactions, as well as with dexmedetomidine, there also are withdrawal syndromes associated with abrupt discontinuation. Okay, so as I said, you've got them on the continuous infusion dexmedetomidine. Where can you go from here? A study published in 2015 was examining their institutional practice of patients that had received dexmedetomidine for at least 24 hours. There was no specific institutional protocol for how to transition patients. However, most doses ranged from 0.2 to 0.5 milligrams every 6 hours. The dexmedetomidine dose, as well as the patient's weight and the patient's age, a lot of times guided their first initial therapy as far as starting dose with titrations up as needed. And what these authors were able to show that after around 33 hours, clinicians were ready to start transitioning patients to clonidine, with pretty successful transition achieved within 48 hours of starting. There was no difference in occurrence of pain, agitation, and delirium scale scores that were out of the goal range during any time in their transition, as well as probably one of the biggest things that I wanted to see was there's no difference in hemodynamic adverse effects in patients. Patients were transitioned, were tapered off of clonidine with around 2 to 2.4 days, as well as the authors did also estimate some potential drug cost avoidance by switching to a much more economic agent earlier on in patients. A similar study was published in the same year evaluating dexmedetomidine being transitioned to clonidine, where the previous study actually excluded cardiac ICU and cardiac surgery ICU patients. This study actually found that their institutional practice had the majority of use within their cardiac surgery patient population. Lower starting doses at around 0.1 milligrams titrated every 6 to 8 hours. Within the first 8 hours of clonidine, they were able to successfully transition 65.4% of patients, and there was no need for reinitiation of dexmedetomidine within 24 hours. No difference in hemodynamic adverse effects, and something that I find very interesting as a pharmacist, and knowing that transitions of care are becoming something really important for us with our patients, there were 54% of patients that were continued on ICU discharge on clonidine, started specifically for a sedation and agitation reason, as well as 23% of them did go home on clonidine with no real indication at the beginning of their hospitalization to be on this agent. So this is something that as we start to think of novel agents, we must keep in mind going forward. So remaining questions. We know that benzodiazepines are no longer recommended as a standard care sedation in our critically ill patients. So what's the incidence of delirium when we're examining head-to-head initial use of dexmedetomidine versus propofol? This was something that you might be saying, was this studied in PRODEX? And it was, however, it was a secondary endpoint, and the patients were not given a standardized delirium score. So for example, the CAM-ICU. They were not given the CAM-ICU until 48 hours after recognition of a clinician recognizing the patient had delirium. So it becomes a little difficult to apply without that information specifically being standardized. Haloperidol used to treat delirium in critically ill patients is not supported by clinical evidence. So potentially the guidelines recommend you may be able to use quetiapine to shorten the duration of delirium. But is there a difference in the duration of delirium when we compare dexmedetomidine to quetiapine? This to me is an interesting question. If we have to use an agent, can we start crossing the mechanism of action drug class and mixing them and comparing them head to head? So in conclusion, dexmedetomidine does decrease the incidence of delirium compared to benzos when used as a sedative agent. It does effectively treat hyperactive, agitated delirium in both intubated and non-intubated patients. Clonidine as well can be used as a method to transition off dexmedetomidine when patients are appropriate for oral medication or even ready for transfer to the floor. So I personally cannot recommend the use of dexmedetomidine over propofol to decrease the incidence of delirium specifically. It needs to be something that we would individualize our goals for sedation for the patient when choosing dexmedetomidine over propofol, but if I'm specifically going for delirium, I can't answer that question. Dexmedetomidine can be used to treat delirium in critically ill patients refractory to or unable to use atypical antipsychotics, as well as patients receiving oral clonidine initiated in the ICU should go to the floor with it already discontinued or with a clear plan to the team taking over of why it was started with a taper in place to get patients so that we are discharging on appropriate medications. All right, thank you.
Thanks, Dr. Roach. So our next speaker is Dr. Heather Torbick. Heather's a critical care pharmacy specialist at the Cleveland Clinic, and she's going to be talking about the use of atypical antipsychotics. You've heard some skepticism about the use of these agents for the management of delirium, so I'm very interested to hear her take on this and potential management and also some potential problems with using antipsychotics for ICU patients. So please join me in welcoming Dr. Heather Skrobik.
Hi, good morning, everyone. So I will be talking about atypical antipsychotics in the intensive care unit. No disclosures to mention. So I will be talking about some of the primary literature that's going to be looking at both the prevention and the treatment of ICU delirium using atypical antipsychotics. We'll be talking a little bit about the pharmacology of these agents and how we can maybe use that to help us treat patients based on patient-specific factors or some of the goals that we're trying to obtain when using these agents. And then just discussing the overall role of maybe where these agents fit in terms of managing patients with ICU delirium. So the incidence of ICU delirium ranges in studies from 45% to 87%. This is likely due to reporting from different critical care subspecialties, variable levels of severity of illness, and then also thinking about how we actually detect delirium in patients and what routine screening tools we're using to identify patients who are delirious. Some of the outcomes associated with delirium include the increased need for chemical sedation, which can prolong ICU length of stay and hospital length of stay. And in fact, patients with delirium have been noted to have increased hospital lengths of stay 10 days longer than those patients who don't develop delirium. Increased mortality, with one study in 2004 finding a 3.2-fold increase in mortality in 6 months compared to those patients who did not develop delirium. And then long-term cognitive impairment, leading to more patients not being transferred home after ICU discharge or hospital discharge and needing long-term care facilities. This ultimately increases the cost of healthcare in our country, which is a huge problem. The exact pathophysiology and pathogenesis of ICU delirium is not known and is definitely thought to be multifactorial and based on a lot of different risk factors that we talked about earlier. One of the biggest ones that I want to highlight are the alterations in monoamines, particularly dopamine, and that's one of the areas where we think that maybe atypical antipsychotics may be of help to us, thinking about these alterations in our monoamines and acetylcholine depletion. Some of the neurotransmitters associated with ICU delirium include acetylcholine, dopamine, histamine, and serotonin. And our subtypes of delirium are based on either the depletion or increase of these levels. So for example, in hypoactive delirium, there's actually increased levels of dopamine and serotonin, whereas in hyperactive delirium, there are decreased levels of serotonin. And histamine, both depletion and excess, has been associated with delirium as well. I won't go over all of the risk factors, but a couple that I want to highlight are those with medications. So thinking about benzodiazepines, opioids, and corticosteroids that have most commonly been associated and linked to ICU delirium. Are there other agents that we can use to potentially decrease our use of these agents in the ICU and potentially decrease ICU delirium then in those patients? So thinking about maybe can we use atypical antipsychotics in place of some of these agents or minimize our use of these agents to decrease our risk for delirium by using these agents that are potentially deliriogenic. So as I mentioned, the cornerstone of prevention of ICU delirium is still going to be our non-pharmacologic strategies, decreasing the amount of sedation that we're giving to patients, preventing oversedation, using protocols to help us decrease the amount of sedation and analgesia that we're giving to patients. Early mobilization has great benefit in terms of delirium risk in patients. And then moving into the pharmacologic interventions, Erin talked about dexmedetomidine, but where do antipsychotics fit in terms of both the prevention of delirium and moving into treatment? I know this is a talk on atypical antipsychotics, but I wanted to start with haloperidol first for the prevention of ICU delirium. There are 3 studies that I'm going to highlight. One is a large retrospective evaluation of haloperidol for the prevention of delirium, and this is in a critically ill patient population, mostly medical ICU patients. And then there are 2 actually placebo-controlled trials looking at haloperidol. What you can see is all of these studies looked at different critically ill patient populations. They all used different haloperidol dosing regimens for the prevention of ICU delirium, and they all found variable results. So despite 2 studies actually finding a benefit in terms of using haloperidol for the prevention of ICU delirium, these studies also found an increase in QTC prolongation and other adverse effects by using haloperidol. So although we may have a benefit in terms of the prevention of ICU delirium, we do have to remember that there are risks associated with these agents as well. So could we use potentially atypical antipsychotics, which have potentially a less risk of adverse effects? So there are a couple studies that I'll highlight. There are 2 studies that were placebo-controlled studies that looked at risperidone, and there is another study that looked at haloperidol, ziprasidone versus placebo. The 2 studies using risperidone looked at this agent in a cardiac surgery patient population, and they found benefit in terms of using this agent for prevention of ICU delirium. The study that looked at haloperidol and ziprasidone is the MENDS study, and in this study, 49% of the patients when they were enrolled were already delirious and 36% were comatose, so that may be why this study did not find a benefit in terms of prevention of ICU delirium. I think this is an area that needs further research. When we think about some of the studies where the patients have been studied, are these patients really at high risk for delirium? The studies looking at patients who received risperidone, those were cardiac surgery or not potentially the most critically ill patient population. They used variable dosing regimens. I still think that there is a lot of data out there that does not necessarily answer the question of whether these agents are beneficial in the prevention of delirium. I think the question that we need to ask is, can we use these agents to minimize the amount of sedation and analgesia that we're giving to patients to potentially reduce the ICU delirium in that way, rather than these agents actually preventing ICU delirium? So I think that's an area of future research. Thinking about treatment strategies, I think, is an area where these agents may have a more beneficial effect. So again, for treatment of ICU delirium, our non-pharmacologic strategies are still going to be paramount to pharmacologic agents at this point in terms of data that we have available to us. But how can we use potentially atypical antipsychotics for treatment once the patient has actually become delirious? There are 3 studies that I want to highlight. The first study was actually published by Dr. Skrobik and colleagues in 2004, and they looked at patients who received either haloperidol or olanzapine in a medical surgical ICU patient population who had delirium. They found that actually the delirium index decreased over time for both groups, both for haloperidol and for olanzapine, but they did find a more favorable side effect profile for patients who received olanzapine compared to haloperidol. In 2010, Dr. Devlin and colleagues actually looked at a medical and surgical ICU patient population also with delirium, and they added quetiapine to patients receiving as-needed haloperidol. In this study, although it was a pilot study, they found faster resolution to ICU delirium, less agitation, and more patients discharged home who had received quetiapine in addition to PRN haloperidol than those patients who were receiving placebo. And finally, in 2015, there was a study published that looked at medical and surgical ICU patients who had hypoactive delirium. This was a retrospective study, and this was looking at patients who received quetiapine versus those patients who had no intervention. The duration of delirium was significantly reduced in patients who received quetiapine. They had no differences in ICU length of stay, hospital length of stay, or mortality. But what was interesting about this study is that when they looked at patients who had received quetiapine sooner than those earlier, they found that patients who received quetiapine early had a shorter duration of delirium, and they had faster resolution of mechanical ventilation, shorter ICU and hospital length of stay. So I think one of the things that comes out of this is, one, can we use atypical antipsychotics to treat ICU delirium? But also, when do we initiate atypical antipsychotics for patients who are delirious? And I think one of the things that there are varying different patient populations in these studies, there are different dosing regimens, but one thing that I think we might be able to pull from this data is if we implement these agents sooner rather than waiting until our patients are very delirious and beyond a point where we can help them, these agents may actually have a benefit in patients early. So we know that our patient is delirious and we need to give them something. How do we decide which agent to use? So looking at first generation and second generation antipsychotics, one of the biggest differences is in first generation antipsychotics having that lower ratio of serotonin to dopamine blockade, which is why they have a greater incidence of adverse effects, particularly extrapyramidal side effects. So maybe our atypical antipsychotics are more favorable in our critically ill patients to avoid these complications. Now we have plenty of atypical antipsychotics to use, so how do we decide which one to use? So the receptor affinity for these agents is going to tell us basically how they work in terms of side effects and what potential side effects we can expect to see from these agents. So for example, an agent like quetiapine has higher affinity for dopamine and serotonin, which may help this be more sedating in these patients and have fewer adverse effects because it has less activity on muscarinic receptors. One of the challenges with atypical antipsychotics, however, are the dosage forms that they are available in. Most of these agents are oral agents only, so our patients that do not have access for oral agents, we may have trouble using these agents in these patients. And the other challenge with using these agents is their onset of action. So the shortest onset of action for any of these agents is 1 to 2 hours, which in a patient who is acutely agitated, these may not be the best agents to be able to administer to our patients. Olanzapine does have an IM formulation, which has an onset of 15 to 45 minutes, but we do not have any data using this agent in patient with ICU delirium. I think one of the things that makes us nervous about using atypical antipsychotics are the adverse effects. And again, as I mentioned, their receptor affinity is going to lead to the amount and type of adverse effects that they are going to have. So for example, olanzapine and quetiapine have more activity on histamine receptors. Therefore, they're going to be more sedating than some of our other atypical antipsychotics. And I know the big adverse effect that everyone is concerned about is QTC prolongation. So this has mostly been linked to patients who already have predisposing risk factors for QTC prolongation, or they're on other medications that are also predisposing them to QTC prolongation. Ziprasidone does have the highest incidence of QTC prolongation, followed by quetiapine, olanzapine, risperidone, and actually aripiprazole may actually decrease the QTC interval rather than prolong it. So it may be something worth considering in your patients who already have a QTC, prolonged QTC, and you're looking for an atypical antipsychotic to use in these patients. In addition to some of the adverse effects that I have mentioned on the previous slide, there are some serious adverse effects that have been associated with these medications. These have been noted in large observational studies of patients who are greater than or equal to 65 years of age and are not using these patients for ICU delirium. However, I think that they're definitely worth noting, especially when using these agents in some of our elderly patients. Acute kidney injury has been associated with the use of atypical antipsychotics, as well as fatal community-acquired pneumonia. This has most commonly occurred within the first week of administering atypical antipsychotics to patients, and it's thought that this could potentially be due to their activity on histamine and muscarinic receptors, leading to possibly an aspiration pneumonia. And there's also an increased risk of mortality with using these agents in an elderly patient population. Due to some of these risks, this has actually prompted the FDA to issue a warning in terms of using these agents in patients greater than 65 years of 65 years old for dementia. Similar to what Erin mentioned about clonidine, there's a concern with administering these patients to patients in the ICU and not being concerned about continuation of these agents on transitions to lower levels of care. There have been many studies published in the last few months that have looked at the incidence of patients continued on these therapies beyond ICU stay, anywhere from the range of 47 to 85% on continuation. And when they've gone back and looked at these patients, they found that at ICU or hospital discharge, these patients have had resolvement of their ICU delirium and they have no further indication for atypical antipsychotics, yet these agents have been continued. And I think that this is something that we should keep in mind and be cognizant of when we're transitioning patients to different levels of care, especially given the long-term concerns with using these agents and potential increased risk of mortality in patients, especially our elderly patients who we're discharging. Our national guidelines that speak to atypical antipsychotics do not offer strong recommendations in terms of using these agents, and SCCM is the only one that says that we may consider using an atypical antipsychotic for the treatment of delirium. And actually, CMS has issued a quality measure trying to encourage us not to use these agents based on some of the safety concerns that I've already mentioned. So in conclusion, I still think that non-pharmacologic agents and measures are still the cornerstone of management of ICU delirium. However, I think that the duration of ICU delirium may be decreased with the use of atypical antipsychotics, especially if we use them early in patients. I think that we need to consider patient-specific factors in terms of which agent to select. There's not enough data comparing any of the agents to each other, so using their receptor affinity and their risk for adverse effects to determine which agent may be best for your patient. And then also being cognizant of cautious use of these agents and making sure that we're only using them for the duration that's actually clinically indicated for our patients, and being cautious not to continue these agents at ICU discharge or hospital discharge. With that, I will conclude. Thank you.
Thank you, Dr. Torbett. So our next speaker is Dr. Catherine Kim, and she's going to be talking about a very interesting drug, ketamine, that's been making a comeback over the past several years for use of sedation, use in pain regimens, even used for refractory seizures. So very interested to hear about the use of this drug in this setting for management of sedation and delirium. So Catherine Kim is a critical care pharmacy specialist. She practices at the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania. So please join me in welcoming Dr. Catherine Kim.
Good morning, everyone. So thank you, everyone, for joining us this morning to talk about ICU sedation and delirium management. Today, I'm here to present alternative sedation strategy using ketamine. Since I have a very short amount of time, I'm going to focus on these three objectives. First, describe the benefits and risk of continuous infusion ketamine in critically ill patients. Second, analyze the recent literature evaluating the use of ketamine for ICU sedation. And I'm going to end with discuss the risk of ICU delirium in patients receiving ketamine for sedation. Before I start talking about unique pharmacological properties of ketamine, I'm going to start with the patient case. This is the patient that I took care of in ICU a couple months ago. So VG is a 32-year-old Caucasian male who presented to UPMC for management of acute pancreatitis induced by chronic alcohol abuse. On day 2 of ICU admission, he was intubated for hypoxia. On day 3, he was diagnosed with the ARDS. So CCM team decided to paralyze this guy for better oxygenation and ventilation. And current regimen that he was getting for analgesia sedation at the time was fentanyl 400 mics per hour and midazolam 12 milligrams per hour. He was also requiring high doses of vasopressor, as you can see here. So the team actually considered 3 options. Option number 1 was just increase the doses of current regimen. Option B, adding propofol to the regimen. Option C was, how about some ketamine? So if you guys don't mind, can you raise your hand if option A, do you think that's reasonable for this patient? Okay. How about B? How about C? Okay. So hopefully by end of this presentation, you have a better understanding of ketamine and its trade-offs and the clinical situations that make sense to use this drug in the ICU. So analgesia and sedation are integral components of ICU care. They help patients' tolerance of mechanical ventilation, facilitate ICU daily care, and decreases patients' anxiety. We often use IV opioids and benzodiazepine and propofol to provide analgesia and sedation. Since the PAD guideline was published in 2013, clinicians have been promoting analogous sedation and light sedation to have a better outcomes at the end. Even though we know that data supports using minimum level of sedation, sedation should be tailored towards everyone's clinical needs. And as you can see, we have problems with opioids and benzodiazepine propofol. We do know there's an adverse effect profile there. And we also went through some shortage issues with the sedating agent a couple years ago. So clinicians actually have sought out alternative sedation strategy using antipsychotics and Precipitating and ketamine. So the PAD guideline, which was published in 2013, briefly states that ketamine is a non-opioid option for non-neuropathy pain. And for sedation, they mentioned that they prefer benzodiazepine-sparing strategy, but do not mention ketamine. So even though we are still lacking data on ketamine for ICU sedation, this agent still continues to be used in the ICU. So we actually need more data on dosing regimen, adverse effect profile, and clinical monitoring parameters in critically ill patients are warranted to help us to use this drug more appropriately. So before I'm talking about mechanism of action of ketamine, I'm going to start with a brief history of ketamine. So ketamine was first synthesized by Dr. Kelvin Stevens in 1962 while he was working for Park Davis Laboratories. At the time, his job was to create a PCP-like molecule, but less likely to cause seizure and neurotoxicity. So in 1964, first human received the ketamine as anesthesia. In 1965, the initial data coining the term dissociative state was published. In 1970, ketamine was actually approved by FDA as anesthetic. In 1999, ketamine was classified as a controlled 3 substances. So we know ketamine is a well-established anesthetic that has been in use over 50 years. It's a unique drug due to its unique pharmacologic properties. So ketamine has a variety of targets, but the main mechanism of action comes from the non-competitive NMDA receptor antagonism. So as I said before, it's a PCP-like molecule, so it dissociates thalamus from the limbic cortex, producing dissociative state. This is a very unique state because it prevents your higher centers in the brain from perceiving auditory, visual, painful stimuli. And this effect is very unique to this anesthetic compared to other drugs out there. Also, ketamine interacts with a few opiate receptors, causing profound analgesia. So the clinically available ketamine is actually a racemic mixture of 2 isomers. And S isomer is 2 to 3 times more potent as anesthetic and analgesic than R isomer. And ketamine, not like benzodiazepine, propofol, fentanyl, we commonly use in the ICU. It actually causes all 3 amnesia, sedation, analgesia. So again, this effect is very unique to this drug. Ketamine is lipophilic, so has a very short onset of action and metabolized by the liver. So there is a potential for accumulation of the parent drug and active metabolite in patients who's receiving this drug for a while and they have hepatic insufficiency. So the common indications of ketamine, as we know, first FDA-approved indication was anesthesia, but in the ER and ICU, you use ketamine for procedure sedation, and we use it for induction agents for rapid sequence intubation, and the low-dose ketamine has been used for treatment of pain. However, this list actually keeps growing. So recently, there's a great interest of using ketamine for treatment of depression, and ketamine has been used for management of the refractory status epilepticus. Hopefully, with the new guideline that's coming out in 2017, we can have ketamine's indication with ICU sedation. So now that we talked about the unique pharmacological of ketamine, and then we looked at the growing list of indications for ketamine, I'm going to talk about the benefits and risk of ketamine. So starting with the benefits, ketamine actually, the popularity as an agent for minimum maintenance sedation in ICU has to be related to its favorable effect on the cardiovascular pulmonary system. So ketamine protects your airway reflexes, increases lung compliance, and decreases the airway resistance, and less likely to cause respiratory depression, which is unlike propofol and benzodiazepine we commonly use. Also, ketamine increases the systemic catecholamine concentration by inhibiting their reuptake. So this will lead to increase the blood pressure and heart rate. Ketamine also doesn't have an opioid-induced ileus problems. It's very cheap compared to other agents. Also, ketamine comes with the side effects that sometimes limits our use. So it increases the pulmonary secretions, and ketamine, in the absence of autonomic control, it can act as a direct myocardial depressant. So hypotension and cardiac arrest can happen in patients with the diminished myocardial contractility. And in these patient populations, ketamine's negative inotropic properties overshadows its indirect sympathomimetic effect because their endogenous stores of catecholamine have been already depleted. And lastly, another side effect that sometimes limits its use in the clinical setting is its psychomimetic effect, also known as emergence reaction. So patients with the emergence reaction presents with psychosis and hallucinations. It has been reported up to 30% of adult patients who is receiving ketamine. It induces perceptual disturbances, which can happen during and after emergence from anesthesia, and hallucinatory reactions can happen during recovery too. Even though we don't have a neurochemical basis explaining the emergence reaction has been determined yet, we have a few risk factors that has been associated with the emergence reaction, including increasing age and female gender. And the large doses of ketamine as a risk factor for emergence reaction is actually controversial, and the efficacy of pre-medication with benzodiazepine to prevent this is also uncertain, and I'll explain this on the next slide. So ketamine's data is more available using for post-op pain. I'm going to use this data to explain the emergence reaction. So this is the meta-analysis published in 2005 in Pain Journal. It is meta-analysis, so the authors searched for randomized comparisons of ketamine to inactive controls in surgical patient populations, including both adults and pediatrics. And they evaluated pain outcomes, opioid sparing, and adverse effect profile. As I mentioned before, they couldn't find a relationship between the dose of ketamine and the risk of hallucinations. And they mentioned that ketamine is associated with the visual disturbances and nightmares, and each were defined in 13 trials. But more interesting section of the result comes from the hallucinations. So interestingly, ketamine, this authors broke down patients into two groups. Patients who received the ketamine during the general anesthesia, and patients received the ketamine while they're awake or sedated. So if you look at the first group of patients, even though they didn't get the benzodiazepine pre-medication, they didn't have reports of hallucinations. If you look at the second group of patients, either they get the pre-medication or not, they all associate with the hallucinations. And more importantly, if you look at the second group, the patient who did not get benzodiazepine pre-medication, number needed to harm at the time was 21. So authors had two conclusions after this. So the first one was, if you are getting ketamine for general anesthesia, ketamine-induced hallucination is actually minimum. And number two was, benzodiazepine should not be considered as a generally effective agent to prevent hallucinations. Moving on to the recent literature on ketamine used for ICU sedation, I'm going to present this randomized controlled trial. So there have been 6 randomized controlled trials used at 24 hours, at least 24 hours of ketamine compared to other agents. However, I'm only presenting this one because this one was actually using ketamine for analogous sedation. The rest of the trials are using high doses of ketamine in neuropatient populations, and they actually evaluated cerebral hemodynamics and the cardiovascular effect and GI motility function. And the patients they looked at was less than 30. So this is actually at least 93 patients. So I'm going to present this one. So in 2003, this prospective randomized double-blind trial actually, the authors looked at the analgesic effect of ketamine in surgical ICU patient population after their major abdominal surgery. So everyone in this group received the morphine PCA, and they either received the placebo or ketamine infusion for at least 48 hours. So the results was, the cumulative consumption for morphine was lower in ketamine group, but there was no difference in the Ramsey score or the difference in hallucinations. So authors concluded that ketamine, the low-dose ketamine, was actually valuable adjunct to opioids in surgical ICU patients. However, this is hard to extrapolate the data to other patients who cannot report the cell pain or who are not able to use the PCA, or patients that are going to require deep level of sedation. So next 5 trials I'm going to present are smaller studies, and most of them are retrospective. However, the interesting point is that most of them are presented, published in the last 2 years. So the first one is the pilot multicenter prospective double-blind trial, including 5 of the mechanically ventilated patients, and they received the continuous infusion of ketamine or fentanyl at least 24 hours to achieve the Riker score of 4. At the end, the higher MAP was found in patients who received the ketamine, and the decrease in the airway resistance also in ketamine group, but there was no hallucinations or nightmares reported that. So next trial is actually my colleague's work from UPMC. She published it, she actually presented this at the SCCM meeting, the single center retrospective study, including 43 patients, mechanically ventilated patients. And intervention at the time was that ketamine was used for adjunct sedation using ketamine adjunct sedation, and then the result section was that patients' Riker score was achieved in 69% of the patients, and at least one of the alternative sedation was decreased or discontinued 60% of the patients. Looking at the last 3 trials, again, most of them are published last 2 years. The first one by Whiteman and colleagues published in 2015. This was the case series including 12 of the MICU patients. Intervention at the time was the ketamine infusion, and median initial rate of ketamine infusion was 0.3 milligrams per kilo per hour. At the end, ketamine was discontinued secondary to tachycardia and hypertension in 2 patients out of 12. And there was no incidence of hallucinations or other neurologic adverse effect reported at the end. Another trial, which was the single-center retrospective study, including 30 patients who were admitted to ICU from the ED, and they're mechanically ventilated more than 24 hours. Intervention at the time was ketamine infusion started at 0.5 milligram per kilo per hour, and median dose was at 2 milligram per kilo per hour. 4 out of 30 patients actually switched to another agents, and 2 out of 4 patients who had an adverse effect, it was due to atrial fibrillation, and the other half was because of agitation. The last trial, which was a case report published in 2016, this is a patient who was a 72-year-old female admitted to neurosurgical ICU for the management of her care. And ketamine infusion was started at higher dose than other trials that I mentioned earlier, 1 milligram per kilo per hour. And she was able to wean off of fentanyl, midazolam, and propofol at the dose of ketamine 5 milligrams per kilo per hour. But there's no report of her hallucinations or adverse effect on other neurologic outcomes. Just to summarize what I just presented, ketamine is actually, there's a great interest of using ketamine for in ICU for critically ill patients. However, there's an insufficient number of randomized controlled trials in the ICU setting. As I mentioned before, there are only 6 randomized controlled trials using more than 24 hours of ketamine infusion, and most of them have a small sample size, less than 30 patients they evaluated. And they mostly focused on achieving sedation goals and hemodynamic effect. The problem is that we don't know what dosing regimen we should use. Even though 6 trials I just briefly went over, there's differences in dosing regimens they use. So patients who's requiring a deep level of sedation, which I didn't mention, there's 5 randomized control trials who use this. Their dose at the time was 2 milligram per kilo per hour to 6.2 milligram per kilo per hour. So it's pretty high dosing range here. And we still don't have a maximum dose of ketamine established yet. So if you look at the SCCM guideline in 2013, they recommend the doses, which is very low dose. So it's more like using for analogous sedation, but we still don't have a maximum dose established by the guideline. Lastly, I'm going to talk about the risk of ICU delirium with the ketamine. So ketamine has a well-known psychomimetic effect when it's used in post-op pain or procedural sedation. And there's maybe possible predisposition to delirium in critically ill patients. However, we only have a small number of retrospective studies evaluated clinical outcomes, including hallucinations, nightmares, and agitation, but we still need a larger trials to evaluate this. And it's really difficult to assess patients when they're requiring deeper level of sedation, like the patient case I presented. If they're requiring fentanyl 400, midazolam 12, and ketamine infusion to sedate them before paralytics, it's hard to assess or use our validated tools to assess their ICU as delirium. So I recommend that there should be a gradual dose titration and close monitoring of the psychomimetic effect when you're using this. So my recommendation for this presentation, ketamine, as I think Dr. Balas mentioned earlier, there is ICU delirium which has a modifiable risk factors, and some of them are related to medications such as benzodiazepine and opioids. Maybe ketamine can be used as a benzodiazepine opioid sparing agent, so we can decrease the doses of these agents in patients. However, I think at this point, knowing that ketamine can be negative inotropic properties, it's contraindicated in patients with acute myocardial infarction or decompensated heart failure. And I'd be cautious to use these agents in patients with a history of ischemic cardiovascular disease or psychosis. And again, we still need more data to look at the ketamine used for ICU delirium and the occurrence of the ICU delirium more closely. Thank you.
So thank you, Dr. Kim, for that review of ketamine literature. We have our last and sixth lecture for this session. Dr. Juliana Barr is an anesthesiologist at the Veterans Affairs Palo Alto Healthcare System and an associate professor of anesthesia at Stanford University. She's going to speak to us on the developing management approaches for ICU delirium. Can everybody welcome Dr. Barr to the stage?
Aloha and good morning. Mahalo nui loa to the SCCM and my distinguished panel and the panel moderators, and to all of you who got up early this morning so that you could go to the beach later. So fasten your seatbelts because I have 56 slides, but don't worry, it'll be like a movie when we're done. So I've been tasked with talking about the tiny subject of how to manage delirium in the ICU. And the only important faculty disclosure that I have, as Josh mentioned, is that I was the lead author of the 2013 SCCM PAD guidelines. So what have we learned so far this morning from the previous lectures is that delirium is common. It's a syndrome that consists of 3 cardinal features. It has a variable clinical presentation. There are multiple risk factors and mechanisms. We know that patients who develop ICU delirium that fails to resolve when their sedation is discontinued in a timely fashion have much worse outcomes, and that a variety of medications have limited effectiveness in the treatment of this disorder. So we're kind of screwed clinically. So what I will attempt to do is to talk about what evidence-based strategies do work, mostly non-pharmacologic ones, and to identify effective strategies for implementing delirium management protocols in your unit. So what are the best practices for preventing and treating delirium? I must say there was a little back and forth between Yoanna Skrobik, Michele, and I about whether we should be offended or embrace today's theme. I chose the latter, but I will, this is about as kinky as my slide deck gets, so for those of you who are sticking around hoping for something better, I hate to disappoint you. So we know what the evidence does say about drugs versus non-pharmacologic interactions, and hands down, or teeter-totter down in this case, non-pharmacologic strategies are the horse to put your money on in terms of both preventing and treating ICU delirium. But what do we mean when we talk about non-pharmacologic strategies? Because the bucket's quite large, as I think some of our previous speakers have alluded to. And so here's my top 10 Tinkerbell list. Number 1, optimize pain management. Number 2, avoid deep sedation. 3, eliminate deliriogenic medications. 4, get them off the ventilator as quickly as possible. Are your seatbelts on? 5, remove lines and tubes, avoid restraints, reorient your patients routinely, promote normal sleep-wake cycles, mobilize patients early, engage ICU patients and families, and oh, by the way, you have to take care of them. So what exactly do we mean when we talk about optimal pain management? Well, the PAD guidelines tell us that all patients in the ICU, regardless of whether they have a surgical incision, should be routinely assessed for pain at least every 2 hours and more often as needed, using numerical rating scales in patients who can self-report, still the gold standard, and a behavioral pain scale. In the guidelines, we recommend CPOT or BPS for those patients who can't self-report. All significant pain should be treated using an appropriate pain management strategy based on the type and location of pain. And the recent acute pain guidelines specifically recommend that a multimodal pain management strategy be used for surgical ICU patients to both reduce opioid side effects as well as improve overall pain management and patient satisfaction scores for the CMS inclined out there, and to reduce the risk of long-term opioid addiction. So deep sedation or medically induced coma is a strong risk factor for patients with ICU delirium. We've heard that this morning, as well as prolonged mechanical ventilation and mortality. Deep sedation can be avoided by using a structured approach to managing ICU sedation, and the PAD guidelines, again, gives us a clear roadmap to achieve this. It all starts with assessment tools, in this case using either the RAS or the SAS and routinely measuring it at least every 2 hours and more often if you think you need to, and then to use those assessments as part of a... Okay, I have like nightmares about things like this. Was that a power surge? Only happens to me. Anyway, back to the slide. So it's important to not just assess their depth of sedation, but actually use that information to titrate medications appropriately with the goal of avoiding deep sedation in these patients. And the PAD guidelines, as I think either Yoanna or Michele alluded to this morning, specifically define what light sedation is, and it's lighter than they opened their eyes when I called their name. They have to actually be able to perform a variety of simple commands. And there are very few clinically acknowledged exceptions to this level of sedation. And there are 3 strategies to achieve light sedation that have been shown to work in the literature. Either a targeted sedation strategy where the nurses are constantly turning the radio knobs on the Alaris pumps to try to maintain that sweet spot of light sedation, daily sedative interruption, and IV bolus dosing. Now, I must say, when the PAD guidelines were first published, all 3 of these seemed to be equivalent strategies that led to the same positive, heartwarming clinical outcomes. But in subsequent studies by Tanaka in this case, they showed that deep sedation, particularly within the first 48 hours of initiating ICU sedation, was associated with a higher risk of in-hospital mortality. And in another study by Shahabi and colleagues, they similarly showed that early deep sedation also was associated with a higher risk of long-term mortality. So I think Michele touched on this, and perhaps Yoanna as well. And some of our pharmacist colleagues, there are a wide variety of medications that have been indicted as exacerbating or causing delirium in the ICU. These are the big 5. I just went to Africa 2 months ago, so I like to say that. Sedatives, opioids, anticholinergics, steroids, and antibiotics. The list is much longer. If you want to look that up, you can find them. And so basically, seemingly almost anything we give our patients as a medication can cause delirium. So mechanical ventilation remains the #1 reason that we sedate patients in the ICU, and yet we know that both mechanical ventilation and sedation are independent risk factors for delirium. So it kind of stands to reason whatever we can do to get the patient off the ventilator sooner, the sooner we can stop the sedatives, and life will be better because we can go back to taking care of the patients in a non-delirious state. So, what can be done to facilitate weaning from mechanical ventilation? Well, these are the kind of 3 big studies. The first one by J.P. Kress, of course, you're all familiar with, showed that there was a significant reduction in mechanical ventilation length of stay if you did daily sedative interruption, or what we now affectionately refer to as spontaneous awakening trials. And then Wes Ely, my brother separated from me at birth, showed that doing RT-driven spontaneous breathing trials also significantly reduced at least the duration of mechanical ventilation. But then Tim Gerard combined those two and showed a significant synergistic improvement in terms of both reducing mechanical ventilation duration and ICU outcomes. So what's not to love? Well, it's complicated. And there's lots of reasons why SATs, even though J.P. Kress published that work, I believe, almost 2 decades ago, haven't been widely adopted because providers, particularly nurses at the bedside who are on the front lines of patient care, are the ones responsible for whatever bad happens to the patient after they emerge from their drug-induced coma. However, we also know that when you use a structured protocol with well-defined safety screens and you sequentially perform SATs and SBTs, but only after patients have passed those safety screens, that you can safely expedite weaning and extubating patient without a significant increased risk of adverse events. So, lines and tubes. I think Michele touched on this. This is a significant risk factor for delirium. Most of that comes from the non-ICU literature, but I see no reason why we couldn't extrapolate that over to the ICU since we use more lines and tubes than anybody else on the planet. And these lines and tubes are often kept in longer than is clinically indicated, quite frankly, because we forget to take them out, or it's more convenient to manage a patient who has a Foley catheter instead of peeing all over themselves and drawing blood from a central line catheter instead of sticking a patient 4 times a day. But what we also know is that if you used structured criterion-based checklists, that you can safely shorten the duration of these invasive devices, which leads to better outcomes, including reduction in delirium risk. We also use a lot of restraints in the ICU, and I think as Michele pointed out, restraints are often used because patients are confused or delirious or both, and yet it becomes a self-fulfilling prophecy because we also know that restraints are an independent risk factor in ICU patients. The odds ratio of developing delirium if you didn't have it before when they put your restraints on goes up by 33-fold. I'm not sure I could count that high. So the other thing to remember is when you stop the restraints, substituting physical restraints with chemical restraints is not necessarily a winning strategy either in terms of preventing ICU delirium. So reorienting ICU patients is more important than you would think. This is a very low-tech intervention that even your kids could try at home to you. This was a really nice study done by Colombo and colleagues where they instituted a multimodal structured reorientation strategy that they applied to every patient every day in the ICU. And it was a before and after intervention protocol. And basically, they showed a 30% reduction in delirium by just doing that. And you can see up there what the elements are of their reorientation protocol. Promoting sleep. Several of our speakers have talked about the importance of sleep. I know I haven't had enough this week, and I'm feeling a little CAM-ICU or ICD-SC subsyndromal this morning. I also can't talk. But what we know is that these are normal sleep patterns, is that a normal sleep pattern consists of a 90-minute cycle. And for the first 80 minutes of that 90 minutes, you cycle from light to deeper levels of non-REM sleep and then culminate in REM sedation. And this cycle repeats throughout a normal course of the evening, unless you're a night shift worker. And during each subsequent period, your restorative REM sleep period increases. Not so much in ICU patients. These are 24-hour polysomnography recordings, I had to practice that, in 8 different ICU patients. And I think you can see it looks like a Richter scale, but basically what's happening and not happening here is that these patients during the night have frequent awakenings. They have severe sleep fragmentation with the absence of normal sleep-wake cycles. They have minimal slow wave and REM sleep. and they have reduced nighttime sleeping and increased daytime sleeping. So basically, their sleeping is totally screwed up. Now, there are a whole bunch of causes for sleep deprivation in ICU patients. I think providers are the biggest offender. We do our best to keep patients awake during the night, and then we feel bad about it, I guess, because then we promote daytime naps. Also, untreated or inadequately treated pain, a variety of medications that we also give to sometimes, quote-unquote, facilitate sleep, paradoxically interrupt normal sleep patterns, mechanical ventilation, how sick patients are, and whether or not they're delirious. So this was a study of nighttime patient interactions in an ICU, and these 50 patients were tracked over 147 nights, and they basically found that rush hour for patient interactions was right at midnight. And my personal favorite, you could get a bath almost any time once the sun went down, all the way up until 6 a.m. I'm not getting that in my hotel. I just want to say that. So, and also, only 6% of these nights was there any sort of prolonged, we'll call it, 2 to 3 hour periods of sleep where you might actually have 1 or 2 normal sleep-wake cycles. Now, we know that people who are sleep-deprived have a higher incidence of delirium. We know that people who are delirious have a higher incidence of sleep deprivation. What's the chicken? What's the egg? Nobody's really sure yet. But what we know is that both these things equally lead to badness, increased PTSD, functional and cognitive impairment, and my personal favorite, death. So what can we do to avoid badness? So ICU sleep hygiene programs, do they work? The short answer is yes. And if you take a structured and disciplined approach to promoting nighttime sleep by creating what various ICUs have called a protected sleep or quiet period, where you're minimizing the clustering of patient care activities, you're not flipping the lights on and off like you're sending SOS signals. And as several of our speakers have noted today, I think Michele, don't play rap music at 3 in the morning in the patient's room. And also the simple low-tech interventions of applying eye masks and earplugs to patients at night. These are all evidence-based strategies that have been shown to work. Relaxation techniques, you can get a massage for free, and not giving sedatives or caffeinated beverages in the evening, while also promoting daytime wakefulness. Get them out of bed, run them around. I don't know if Heidi Engel, my physical therapist heroine, is here today, but what she would tell you is it wears people out to move them around and have them actively participate in exercise during the day. Open their window shades during the day and avoid daytime naps. And the literature on melatonin is not ready for prime time yet, but there is a large ongoing, I've been waiting breathlessly for this, trial by Wang and colleagues. I don't know if they've completed enrollment, but stay tuned because I think that will address some of the issues that our speakers raised about the role of melatonin in promoting sleep and reducing delirium. So mobilizing patients, early mobility. So ICU-acquired weakness is a common phenomenon. It is a syndrome, really, not a disease. It can either be a myopathy or a polyneuropathy, but either way, patients become weak as a baby very quickly. If critically ill patients lie in bed for a week and they don't get out of bed, they lose 30% of their muscle mass and close to half their strength. There's lots of reasons for this. And generally patients who develop this have a significantly higher risk of both short-term and long-term complications. But my personal favorite, regardless of age, is that 50% of patients fail to return to their previous level of physical function because they're too weak and they just have no stamina. I think Dr. Ely told a very elegant story about such a patient yesterday. So when we talk about mobilizing ICU patients, we are not talking about passive range of motion. No, sirree. We are talking about getting them up and moving them around and having them sit up without assistance and then ambulating, if not running down the hall with their walker. I've almost been run over several times. I feel like we should have a traffic cop in my unit. And we know that when you actively engage patients physically, that you decrease their length of stay, sedative use, deep sedation, delirium, and you increase their functional status at discharge, so they're more likely to go home instead of to a SNF, which would be my first choice if I were one of those patients. As I said, deep sedation is often the endpoint in mechanically ventilated patients, but light sedation is what is necessary if you're going to get patients like this out of bed, unless you really believe in zombies. But most patients who are deeply sedated can't participate in early mobility. So if you don't wake them up, you never get to this. Judy Davidson and Randy Curtis, hot off the press, just published the updated version of the patient and family support guidelines. This, I think, is really going to help backstop the F element of our cute little bundle. And they actually have some very concrete suggestions for what family engagement looks like in terms of improving family presence, family support, facilitating qualitatively and quantitatively communicating with ICU family members, increasing palliative care involvement, using winning strategies to reduce conflicts over goals of care, and create ICU policies for how end-of-life sedation analgesia will be managed, and create a sleep-enhancing environment for both ICU patients and their families who are staying there around the clock. So one important way to engage ICU families is to actually bring them into the conversation, and the best place to do this is on daily interprofessional team rounds. Here we have a picture of the entire ICU team and the family at the bedside. I don't know, just a show of hands, how many of you systematically involve patients on rounds? Oh, there's hope. So the rest of you, I want to see your hands next year, but people who don't do this say it's too time-consuming, they're going to hold us back, they're not going to understand what we're saying, we're going to freak them out. And that, anecdotally at least, nobody studied this yet, please do, has not been our experience in the ICU Liberation Collaborative, which I'll talk about more. In fact, just the opposite. Engaging families on rounds increases trusts. They actually stop being human hovercrafts in the ICU because they're afraid you're going to do something and you haven't told them about it yet. And they feel much better, and it improves their family satisfaction scores. Again, you little CMS people in the audience who care about those things. Okay, so home stretch. So what is it going to take to implement this top 10 laundry list, which looks daunting? I understand that. We've simplified it for you at SCCM. We're here to help. And so we've created this cute little innocuous-looking bundle that basically rolls the PAD guideline recommendations into 6 letters, although the F was added as an afterthought. Again, I won't go into that. Wes did yesterday, but an important one nonetheless. And the objectives of this bundle are not only to reduce the incidence of ICU delirium, but also to optimize pain management, avoid deep sedation, reduce duration of mechanical ventilation, and improve mortality, length of stay, and long-term cognitive and physical dysfunction, and reduce health care costs. It's basically mom's apple pie versus alphabet soup. Okay, but why a bundle? So we know from Peter Pronovost's work and IHI that bundles are good if they consist of evidence-based elements, which this does. And why are they good? Because they standardize care processes, they reduce provider variation, they improve ICU communication, they ensure that every patient gets the intervention every time. And this all translates to typically better outcomes than if you did the individual bundle elements in a non-coordinated way. So how to think about this using a structured, rigorous QI approach is also a winning strategy. Interdisciplinary stakeholder team should be assembled. Find a clinical champion. They don't have to have an MD after their name. Perform a gap analysis on what you're currently doing. What's the state of affairs in your ICU? Educate the heck out of your staff and keep educating them, especially the newbies that show up a year later. A data collection process should be developed so that you know if your bundle interventions are working and that you can sustain your gains. And incorporating the data elements into your EMR is particularly helpful. More on that later. So you've got a team. You've kind of got a plan where to start. Do you implement A, then B, then C, then D, then E, then F? The shorter answer is no. So in thinking about this in the ICU Liberation Collaborative, we have encouraged people to take a more holistic approach and start with implementing the PAD assessment tools, specifically in the 3 domains of pain, sedation, and delirium. Then from there, incorporate these PAD assessments, get it into the drinking water, as Wes likes to say, and on ICU rounds. You incorporate the values into your medication use protocols, link PAD management with SATs, SBTs, engage families, and measure performance. So this is the house of PAD. It took me a long time to make this. You don't know what you don't measure, so that's why we start with the assessment tools. Assessments without protocols won't change practice, and pain, coma, and delirium are barriers to doing the good things on the top. So what do we mean when we talk about getting it into the drinking water? At Vanderbilt, every day they go through this mantra of asking these 4 questions about what the patient's pains, sedation, delirium scores are, and do we have an appropriate treatment strategy in place for this patient, and how is it going to influence our care plan today? When you develop a protocol, and I'm talking to my pharmacist friends here now, you want to make sure it's specific to your ICU culture and formulary. We get emails all the time in the collaborative, like, well, what's your protocol? What's your protocol? What's your protocol? We don't have a protocol. Well, if I sent you my protocol, you would hate it. So make your own, but there's some ways to do that and make sense of it. But protocols help transfer evidence-based practices to the bedside. They limit practice variation. They reduce treatment delays. They improve outcomes. And it helps you to link them to your quality insurance efforts. Once you've kind of nailed down the PAD protocols, the next step is to link it to performance of SATs and SBTs and early mobility. Engage patients and families. Get them involved in care and conversations at the bedside. And finally, measure bundle performance. Otherwise, you don't know if your bundles are working. This is our sustainability plan at the VA Palo Alto ICU. Each letter has a process and an outcome measure, and these are our personal benchmarks. There's nothing written in the golden tablets that tell you this defines your success, but it's something we are reaching for. So how do we know this works? So for those of you at Wes's talk yesterday, he presented Marianne Barnes-Daly, groundbreaking, hot-off-the-press paper about implementing the bundle across 7 hospitals in the Sutter network, and 6,000 patients were involved. And basically what they showed was there was a dose-response effect to implementing the bundle in terms of hospital survival and delirium coma-free days. Basically, as total bundle compliance went up, your odds of surviving went up, as did your delirium-free days. But even partial bundle compliance, as that went up over time, your likelihood of death and destruction and delirium went down. So the ICU Liberation Campaign was launched in 2015. There's been an 18-month collaborative hitched to this wagon, and we're almost done with it. The goal was to help 77 U.S. ICUs implement the bundle over 18 months across the entire country, and we have given them the QI tools to accelerate this process. So stay tuned, because that will be coming to a theater near you probably in the next year. Thank you very much.
So that was great. I hope you can stick around. We have about 10 minutes left for questions, and this is the most important part of the presentation because you get to interact with all these specialists and experts in delirium. So does anyone have any questions?
I've had all my shots. So you can sit down.
Do you want me to start? Or?
Yeah, just introduce yourself and then ask your question.
Sure. My name is David Kramer. I'm at Aurora Healthcare in Wisconsin. And my question relates to the issue of delirium scoring. Do you think there is a way to assess someone who's really, really bats compared to somebody who's a little bit delirious compared to, should we have a scale, and is there an advantage to doing that? I should have said to start with, thank you very much for your presentation.
Thanks. So what you're referring to is delirium severity, and it is not capturable in an ICU because it takes a conversation. So all of the tools that we've got are binary, yes, no. And there's some data that suggests that the more days you're CAM ICU positive, the worse your outcome. And the same doesn't hold true for the ICD-SC, but they're trigger tools. The delirium is present, but the severity issue is a huge limitation in what we're studying, no question.
So, I mean, this becomes an issue when you're trying to capture these data electronically. We have a yes/no, is delirium present? We have a field which says, has this changed? And the nursing staff interprets that as compared to a baseline that existed a month ago. And we wind up with obviously delirious patients scored as not being delirious.
You know, I think that you're absolutely right. And the personality and what appropriateness is for, I was given a stern lecture on what appropriate means for a long-distance truck driver by one of my nurses once, where I thought the behavior was way out of line. But I think there's a cultural component. Who is this person? Where are they coming from? What's their baseline? And how crazy are they compared to that baseline? And I think that's what I was trying to refer to in that. And we don't do that enough.
Hello, my name is Renee Paxton. I'm from Detroit. I'm a PharmD that rounds with the surgical ICU team. We have a lot of patients that have, substance abuse issues, and we've, for patients similar to in the ketamine case that you presented, have refractory agitation or refractory delirium and are hemodynamically unstable. So we've tried using valproic acid, obviously off-label, and we've seen benefit with that. Do you guys have any experience using valproic acid, in refractory situations?
I think that there's beautiful work to be done in withdrawal, whether it be related to alcohol, where we really don't know what we're doing, even though it's such a common issue. But the one patient that I looked after in GHB withdrawal was my broadest pharmacological exploration. I think the bottom line is, I think I've used valproic acid, yes, in those patients where you're maxed out on your propofol, you're maxed out on your benzos, and you're just hitting every receptor you can think of with each molecule that'll chill whatever it is that's going on in their brain. Yeah, so I have. But the literature is sparse. Judy, I don't know if you want to speak to that. It's a huge problem. We really don't know what we're doing.
Yeah, it's an area ripe for research. So, although, especially the young researchers out there, something to jump on. So, in my own practice, I've seen valproic used this many times, and it wasn't my idea. And it was actually a neurologist that we called because we had an elderly guy who was delirious, and he was too unstable to sit down for a head CT, and we weren't sure what was going on. We were throwing the kitchen sink at him and running out of drugs in the pharmacy. Anyway, long story short, we started him on valproic acid on a Friday, and I came in on a Sunday morning, and he was sitting up in bed, extubated, smiling, talking to a family member, and I'm like, this can't be the same guy. So that is not an endorsement of valproic acid, and I'm not, to this day, sure where the neurologist came up with that great idea, but it worked in his case, so...
Gail Allen. I'm the Director of Adult Critical Care Services at University of Vermont. This question is for Catherine Kim. It's about ketamine. Much like other drugs, phenobarbital alcohol withdrawal and whatnot, I've seen ketamine kind of creep into ICU care. Many times under good circumstances, patients on 400 micrograms of fentanyl, oftentimes because they're not being properly assessed for pain, they're not being appropriately reloaded, but nevertheless, we put them on low doses of ketamine. Next thing I know, I'm seeing patients on ketamine for sedation and analgesia, and I'm worried about not so much the delirium. So you talked a little bit about this, but I'm wondering if we are going to be doing long-term studies with ketamine as a first-line sedative in the ICU. We know that PTSD, some of the biggest risk factors for PTSD are these dyscogent or non-cogent memories and loss of large gaps of time. And because it's a dissociative hypnotic, if we're going to be looking at ketamine as long-term sedative, should we not also be looking at outcomes in delirium, but outcomes in PTSD as well?
So I think that's a really good point, because right now, although available data, even though it's limited, are looking at really short duration of ketamine, usually 24 to 48 hours. We really don't have comparative trials looking at ketamine long infusion compared to other agents that we normally use in ICU, like fentanyl drip or propofol. So I think that's a good point, because PTSD is another high-risk things happen in ICU with this patient. And ketamine having amnesia, sedation, and analgesia all happen at the same time, you don't know if they're going to have this memory loss after this. So I don't think there's any data out there looking at ketamine for even PTSD or even ICU delirium, but I think that's something that we can look into.
Yeah, I think we should encourage researchers to look at that if they're going to do this.
Thank you.
You know, I think I just want to say a word about drugs. Don't do drugs. Drugs are bad for you. Did your mother tell you that? There are two studies that are underway that both large multi-center, well-designed, NIH-funded trials, both through Vanderbilt University. One is the Mind USA study. It's a prospective 3-arm randomized trial looking at ziprasidone. Thank you. I always have to ask the pharmacist how to pronounce that. And versus dexmedetomidine versus, I think it's haloperidol. And so that's really the first large prospective ICU atypical trial for the treatment of delirium. What?
I don't think Dex is one of the arms.
Oh, what's the third one? Placebo? Placebo. Thank you. Sorry, more coffee. The other study that Wes and his colleagues are doing is a trial of propofol versus Dex for ICU sedation, looking at the incidence of delirium, because I think, as you mentioned that, or somebody mentioned that the answer about propofol versus Dex and deliriogenic propensity hasn't really been answered.
Morning. My name's Hardy Bredek. I'm a PA with the cardiac surgery division at Stanford. And I had a question. What are your recommendations for management of insomnia in the hypoactive delirium patients when melatonin and quetiapine just don't seem to be doing it?
I'll let the pharmacists who are well prepared to answer that. But you bring up a fascinating point, the use of the atypical antipsychotics for sleep. Yeah. I have no idea where that came from. Yeah. But it seems that we get tons and tons of questions related to the use of an antipsychotic to promote sleep, and it's supposedly getting into the water in clinical practice. I am not aware of any evidence to support that practice.
I think it comes from those commercials with the little butterflies from the drug companies.
It comes from the idea that it disrupts sleep patterns a lot less than propofol or benzos, right? So you don't lose as much REM 3 and 4 with the atypical antipsychotics, and in clinical practice, GPs will prescribe it in low doses for people who can't sleep, particularly the elderly, because it has a lower side effect profile, surprisingly. But I think that in that refractory patient population, one of the drugs that has been brought up as a possible alternative is a low-dose dexmedetomidine infusion at night. And if you look closely at the literature, coming close to a journal near you, there's going to be a publication that actually comments on that very issue. And I think that that's clinically, it's something that I've used. But I have used, I'm sorry to say, atypical antipsychotics for the purposes of sleep, so that they don't get, I don't know a single nurse on the planet that doesn't say when you're tucking in a sleepless patient, can we give him something? And the last thing I'll say is that Rafael Cremonese, who's in southern Brazil, has tuck-in rounds that are very different than the ones I do in Kingston. We ask the nurses, what do you need? Rewrite antibiotics orders. His tuck-in rounds consist of a nighttime massage and tea or a snack if you're extubated. And I want to go to that ICU if I'm ever sick, because I think that's the kind of sleep enhancement tactics that we should be exploring a whole lot more than the drugs.
And getting them exhausted during the day, like Julie said. Really focusing on that early mobilization during the day so that they're so exhausted that they'll sleep at night, and that they're not in their bed or in their chair napping all day and then having to give them a sleeping pill then to promote sleep at night. It's this vicious cycle that can be broken through non-pharmacologic interventions that unfortunately take a lot of time, which is something many people don't have.
So are you then not endorsing or not recommending use of like Ambien or Remeron, things like that? No.
I think it makes patients worse, actually.
Worse. Okay. Great. Thank you.
Unfortunately,
Makes
I think
the nurse
we're
happier.
I think we're out of time, but let's give another warm applause for our awesome faculty today.